The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our October 9 Safe and Calm webinar. This is Deanna Mitchell with Leading Age Michigan. This past week, we know, have been difficult for our members. Nursing homes have visitation options, and then they don't have visitation options. Other facilities are in the same boat. We know what the state rules are, but now we're not sure what the state rules are. We anticipate more changes to the rules, but we don't know when. And it's certainly been a bit exasperating, and we want to acknowledge the diligent work by all of our members to keep seniors and staff safe amid this very, very uncertain time. So we have a lot to talk about this morning. Our agenda, as usual, will focus on the updates, and we will be providing information on all the most recent legal movement and guidance. We're very pleased that Phyllis Adams from Dyke & Gossett will be joining us this morning for a brief discussion of the recent Supreme Court ruling and what it means. Go back, Blake, please. And at least what it means for now. Phyllis has been a long friend of the association and has, as always, we appreciate her wisdom and guidance. Dalton Herbal will be providing an overview of the legislature's movement on key bills as of yesterday, and we will follow with a very brief situation update with a focus on Michigan and what's happening in terms of caseload in Michigan. And then our regulatory updates will focus on the recent emergency orders that Dr. Robert Gordon issued earlier this week and some updates from the CDC. So we will start with a brief overview from Phyllis on Michigan's state of emergency. Welcome, Phyllis.
Thank you very much. So this is such an apt slide, so I really appreciate having that on the screen. We really have to think back to high school civics class here in the three branches of government to understand what's going on here. So this was the legislature examining the authorities that the governor in the executive branch has been exercising to deal with the COVID pandemic. So they said you overstepped your bounds by extending the emergency under the Emergency Management Act. You didn't have the authority to change that statute. We're the legislature. We decide what's in statutes. And because you didn't do that, these executive orders are invalid. Now, of course, that leaves, except for the very first ones, but those are long gone way back in the spring. So this obviously leaves a lot of questions about what do we do now. But there are lots of other authorities that are under the Public Health Code. And as we've already seen, we don't expect the executive branch and the governor to just sort of skulk off and go away here. They're going to continue to try to manage this pandemic by issuing orders under this express authority of the Public Health Code, which is broad. So in section 22221 of, 2221 of the Public Health Code, there is actually a link back to the Constitution that says the department shall continuously and diligently endeavor to prevent disease, prolong life, and promote the public health through organized programs, including prevention and control of diseases. So there's authority there. There's broad powers granted to the Department of Health and Human Services as the current body that administers the Public Health Code. And specific to what we've seen already coming out of Director Gordon's office, that they are issuing now these, quote, epidemic orders under section 2253 of the Public Health Code. Again, that gives them broad authority. It says if control of an epidemic is necessary to prevent or protect public health, the director may prohibit gatherings of people for any purpose and may establish procedures to be followed during the epidemic to ensure continuation of essential public health services and enforcement of health laws. So there's a lot of authority there. There's also sort of ancillary authority that can be delegated to the local health departments to issue epidemic orders. The department can take injunctive action. Violations of those orders can be treated as a misdemeanor and subject to penalties. There are some rights to hearings for individuals that have purportedly violated one of these orders. But again, we'll see how that works. So I think here, epidemic is not a defined term in the public health code in that section. So I think that leaves it to the executive branch to determine when there is an epidemic upon which then they can act. I think the fact that the World Health Service determined that COVID was a global pandemic on March 11th of 2020 and is still in effect, the CDC acknowledges that there is a COVID pandemic in the United States, that I think that provides the basis for Director Gordon to say, look, there is a legitimate issue here and we're going to issue these orders. They're probably going to be a bit more scaled back, perhaps not so wide ranging. And one of the things we don't know is that, this really only impacts certain public health functions. It does not address continuation of businesses in the state of Michigan. It does not address, operations of schools, except to the extent that that rises to a public health issue. It does not address unemployment benefits, kind of wage issues, tax issues. Those would be things that probably could not be addressed under the Director Gordon's epidemic orders. So those will be interesting, but I think on the health part of it, there's some pretty firm ground here for the epidemic orders. And I don't see that the state legislature has to declare the pandemic or has to declare the epidemic in order for those orders to take effect. I think that the director, at least based on a quick review here, and we do not have any case law interpreting or applying these provisions, which have been in the public health code for years. There's sections in the beginning you always skip over because you never used them for anything, but now we're using them. It's a fascinating time. But I think there's ample authority delegated under those statutes which were passed by the legislature. So we've already checked the box on legislative action. We're acting pursuant to a duly promulgated and passed statute in Michigan that granted this authority to the director of the Department of HHS. So again, I think we're going to see a lot more of these. I'm grateful for the wisdom of Leading Age Michigan today to try to explain some of these orders, but I think, again, these are more likely to be upheld just because of that specific authority. We'll have to wait and see. There is an argument here that somebody will complain and say, well, wait a minute, you're getting a little far down the road on these ridiculous orders. There's been a bunch of these now epidemic orders. We think some of this has to be promulgated as actual regulations, still in the executive branch. But we think you need to follow a rulemaking process which would slow things down. However, in the public health code, there is also a provision in there for promulgation of emergency rules. So if someone alleges that these epidemic orders are insufficient, that we actually have to have published promulgated regulations under the Michigan Administrative Procedures Act, like you have other real rules in Michigan that are in the Michigan Administrative Code. There is still a way for, I think, the governor with, ultimate responsibility over Department of Health and Human Services and Director Gordon to issue emergency rules if they need to in order to address some of these issues. So I think on that, that's kind of the overview. We don't have a lot more information at this point, and I think we just have to focus on what should we be doing right now? And I know Deanna is going to provide later in the session a lot of good information about our best recommendations at this time. So thank you.
All right,
Thank you, Phyllis. We're going to go ahead and pause briefly to see if there are any questions for Phyllis before we move on. You can move the slide forward, please, Blake.
Okay. Before we do get into any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo during our annual conference. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. As of right now, I am actually not seeing any questions, so it looks like we can go ahead and move forward.
Okay. So let's go ahead, move forward to Dalton Herbal, our Director for Public Policy.
Good morning, everyone. Hope everyone's doing well today. As you know, everything got a little crazy last week. So I'll be running over what the legislature has been doing in response to the most recent Supreme Court action, kind of what is their priorities and what can we expect to be done within these first two scheduled sessions. I'll also be touching on the formal extension of the direct care worker hazard pay premium increase, the $2 an hour bonus program for direct care workers. Just briefly going over that, is not a lot has changed, but there are some important dates you'll want to know. And it's also important to note that provider liability is one of the concerns of the legislature going forward here for the pandemic, because the Supreme Court decision kind of put some of the immunity protections the governor put into place in jeopardy, or at least that's how I understand it. So they're going to be trying to take some legislative action on that. So if you haven't been following the news, the Supreme Court ruled that the governor's authority to extend a state of emergency without legislative approval was unlawful. And thus the legislature has to respond to help meet some of the important aspects of the executive orders and keep those in place to protect the people of Michigan. And so what they have done, they almost immediately got to work and set 2 session days. The Senate session was going to meet yesterday, so they met yesterday, and the House is scheduled to meet on Tuesday. As you know, the House is up for re-election, so their schedule is a little harder to follow than the Senate, but the Senate met yesterday and did pass some bills, and so we'll dive into those on the next slide. So the Senate and the House, so the entire legislature, really has 5 main priorities which can be expressed through these 5 bills. Almost all of them were passed yesterday, except for the healthcare liability protection bill, so the bill that would protect providers. That bill has been going through the process as normal, with the other 4 being introduced that day. The rules were suspended and then they were voted through. So 4 of these bills were new, and House Bill 6159 is old and followed the original process, and we'll get into more detail about what's going on with that a little later. So the first priority of theirs is to implement dedicated facilities to house COVID-19 nursing home patients during the pandemic. This bill, which we're going to cover in more detail later as well, looks very similar to other bills that they've had regarding COVID-19 nursing home placement. So if you've been following these calls and you remember the last 2 bills that they've passed and then were vetoed, this will look very similar. But that is one of their priorities, is figuring out where are these COVID positive residents going to go. Second bill is the healthcare provider liability bill. I touched on that briefly. It was not taken up for a vote yesterday, and that's due to some very specific circumstances, which we'll cover later. Their next priority was extending unemployment. As you know, if you followed the news, the governor was kind of holding the legislature to task for not immediately extending unemployment benefits. They got in a day after the Supreme Court order, so they were moving pretty quick on this one. But they did unanimously pass this bill. So both sides of the aisle came together and said, hey, let's pass this. It's important to note that the other liability immunity, or the other civil liability bills, were tied to this bill. So the governor wants to sign this unemployment legislation, she'll also have to approve liability protections for everyone except healthcare workers, because that's a separate bill outside of this package. The 4th priority here is to create a bill that would allow retirees from the unemployment agency or MIOSHA to be rehired without losing retirement benefits during the pandemic. They really went in delved back into their retired employees when the pandemic hit to kind of gain back some experience and get some more boots on the ground. So this bill still allows them to do that and still allows those individuals to be hired, which is important for those agencies. The last one is simply to amend the Open Meetings Act to allow for electronic virtual meetings of public bodies. That was done through executive order and is not commonplace, so they do need a bill. That was also passed almost unanimously. 2 people voted against it, kind of on these principles of that open meetings need to be there, and that if you're legislating, leading the state in any kind of a public fashion, you need to be able to be held accountable for your actions in person. So largely all of these passed unanimously except for the healthcare liability bill, but we'll move on to that. It's not necessarily bad news. So as I said, the dedicated facilities bill passed unanimously. This is very similar to a lot of the previous dedicated facility bills. The actual language in this bill says that by October 15th, MDHHS and LARA must conduct an evaluation of the regional hubs and develop and submit a plan for COVID care, for the care of COVID positive individuals to the House and Senate. And if that plan looks like the previous regional hub model, the department needs to incorporate recommendations from the CDC and the governor's nursing home preparedness task force, which many members and staff here at Leading Age sat on. They have to include best practices from those 2 groups in their plan. It also gives the department the authority to implement any other best practices they see into that plan without having to stick to what the old model was. It is important also to note that there is language in there that they must implement dedicated facilities available for the use for only coronavirus positive patients in each of the 8 healthcare regions of the state. So this bill kind of lets us see that they're still thinking 8 healthcare regions and not necessarily on a county level. It'll be interesting what the implementation sees in this bill. Just because it says this, it doesn't mean that the department can't take in CDC guidance or nursing home preparedness task force guidance and kind of focus more on that county level and that local level for transmission and rulemaking. But they do have to look at the 8 healthcare regions and make sure that those are at least taken care of. Also with dedicated facilities, and this is a more, I would think, important part for our nursing home members, beginning November 1st of this year, an individual shall not be admitted or retained for care in a nursing home unless the individual has since recovered from coronavirus or the nursing home demonstrates to the department that it is able to provide a designated area within its facility for individuals who test positive for coronavirus and has a program for retaining and providing the appropriate level of care necessary for those individuals who test positive. This would obviously be troubling and has been troubling in the past for those who have done some research and thought about the idea of unnecessary transfers of residents and their quality of care and quality of life. But it is kind of coming also with the recommendations from the Nursing Home Preparedness Task Force that said you really just have to say that you're able to take care of these people to demonstrate to the department that you're able to take care of these people. So you just have, from what I understand right now, you just have to say that you're able to take care of these people, you have these things in place, submit your plan, and that they'll approve you to take care of these individuals. But we'll see how this rolls out going forward. So what's going on with the provider liability? As I said before, this bill was not taken up for a vote, even though it is one of their 5 priorities. The reason for this is because it has previously been vetoed by the governor, and legislative Democrats talked to the legislative Republican leadership and said, hey, as a legislature, if we work together on this, I think we can get the governor on board with the bill by Tuesday. And then the Republicans responded with, okay, let's set that as a deadline. So right now we have this deadline of Tuesday. The legislative Democrats and leadership on that side of the aisle is going to go to the governor and try to see what her hesitation is with signing this bill. Previously, it was that it created duplicative law because she had extended some kind of provider liability protection underneath the executive orders, but now that those are gone, that is not duplicative anymore. So they're going to go and talk to her and see if they can get her on board. And if not, the legislative Republicans are going to pass the bill on Tuesday and send it to her desk. So we kind of have this interesting dynamic, and hopefully they can get something done and get everyone on board and get this bill signed along with all the other priorities that will help the people of Michigan. Lastly here, we're going to cover the SNF Direct Care Worker FAQ that came out over the weekend. This formally extends that program till 12/31/2020. The reimbursement process is the same, and eligible employees and the hours and payroll tax expenses are all unchanged. You will note that for October, you'll need to submit a separate request because of the changeover in funding pools. And the base wage is that is in effect is of 10/1. So we're essentially just saying, here's another 3 months of the program. Everything applies as it did, but you need to still submit applications as you would. Deadline for the first initial batch of these funds, or July through September funds, need to be submitted by 10/23. So that is your deadline. If you haven't submitted anything by 10/23, the department really doesn't have a lot of flexibility there. So please make sure you get your information into the department if you haven't yet. If you do opt to use the lump sum payment option, the department just asks that you contact them and let them know because it is a little different and they have to provide a lot more funds. So there's their email right there. Please feel free to reach out to them. They've been very responsive every time I've reached out to them. So you're in good hands. And the wage increase is required through the 31st. The wage increase is required only through December 31st if the pay period extends into calendar year 2021. So there you go. That is that.
Thank you, Dalton. Before we stop for another Q&A period, we're going to go through a brief situation update this morning with a focus on Michigan. So moving forward, you can see here Michigan's standing compared to other states in terms of total new cases for the past 7 days. Michigan sits in the second to highest category with between 6,923 and about 12,000 cases. When looking at total cases per 100,000 population, I know this is a hard graphic to see, but this is the ordering of each state and how they do in terms of total cumulative cases per 100,000 persons. Michigan fares right now in the 14th position for the lowest number of cases, which is pretty good overall. Louisiana, unfortunately, leads the group with the highest number of cases. Here's our routine graph displaying the 7-day average new cases for the past 60 days here in Michigan. You can see even that the smooth data has this rhythmic up and down, but that it is trending slightly upward at the same time. In terms of new daily deaths, using, again, the 7-day rolling average, you can see a stronger incline upward. Excuse me. And we'll talk about that upward incline in deaths a little bit more in a later slide. But it's clear here that recently deaths are increasing in Michigan. So in total for Michigan, as of 10/7, almost 100,000 persons have recovered. The death toll right now is heading towards 7,000. And overall, the average number of daily new cases over the past 7 days is 879, and that's pretty high, you know. Not near as high as when we peaked, of course, but it is climbing. The data in this slide is built from the MDHHS published data, and it tracks the relative proportions of persons in different settings for COVID-related treatment. You note that the percent of active cases who are being treated in the hospital are going up. And of course, we've already talked about deaths going up as well. Some researchers think that these increases are actually the result of high caseload during the late summer among young persons. So while deaths and hospitalizations were low during that time because of the high proportion of younger persons infected during the summer, those surges have now reached out into older populations and is currently impacting the proportion of deaths and hospitalizations in seniors. This graphic is also not very clear, but the point about it is the overall positivity rates for Michigan. These are all the Michigan counties lined up. You can see that the county positivity rate is divided into 3 categories: low, medium, and high. We do now, as of last Monday, have 2 red counties on the map. And they're associated with recent surges in the Upper Peninsula. In fact, most of the high transmission counties that you can see here listed are in the upper, and then they also include Iosco and Macomb counties. Members are reminded that CMS requires that you pay attention to the color code rather than the actual positivity rate, since they adjust the color code sometimes for some counties who have really low testing rates and whose data might need to be looked at differently. Here is the MySafe start map as of yesterday. Our overall positivity rate is running 3.5%. And you can see that the upper has moved into the very highest risk category, while Lansing, which used to be in that high risk category, those numbers have now decreased. When looking at this website for your own county standing, you can note that you can pick a region, and we picked Detroit here just as an example, or you can pick a county. So you can pick a region, one of those large 8 regions, or you can pick a county and look at the data specific to that area. If you click on the epidemic spread bar there, you can see the positivity rate for that area over the previous 7 days and the number of new cases per million. Local health departments are paying attention to these numbers, and they do have the ability to alter nursing home and long-term care facility safety requirements in terms of testing and visitation if they wanted to, based on these numbers. So that ends our situation update. Let's pause and take questions either for Dalton or if you have any questions about the data.
All right, thank you, Deanna. Before we get to any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. It looks like I just have one question right now. Where do we find the spreadsheet with all the counties on it listed in red, yellow, and green?
Those are listed off the Nursing Home Compare website. If you, I think, go down, the 3rd bullet on the left talks about the positivity data. You click on that link, it will take you to another piece that talks about the data, and then you have one more link to go. But if you start at the Nursing Home Compare website, it'll take you to that Excel sheet.
All right, thank you, Deanna. Other than that, looks like we are good to keep moving on.
Okay, so let's move on to the guidance and updates. There is an awful lot to talk about here. We're going to start, you can move this slide forward, Blake, with the first emergency order following the Michigan Supreme Court decision that occurred last Friday. This order was from Dr. Robert Gordon and came out on 10/5. It is, of course, intended to supplant the executive orders for basic safety precautions in group settings. For indoor private settings, groups are limited to 10 persons, and these are always about groups of unrelated people who don't live together. So groups are limited for private residential settings to 10 persons. Masks are recommended but not required. For indoor non-residential settings, groups are also limited in general to 10, and masks are required. Larger groups, though, can convene. Up to 500 persons can gather if they're wearing masks and they apply social distancing, as long as there's a limit to setting capacity to 20% of normal capacity if they have fixed seating, and no more than 20 persons per 1,000 square feet if seating is not fixed. There's similar kinds of requirements for outdoor groups. If you're in a residential setting, 100 persons can gather outdoors, and again, masks are recommended for that group. For non-residential groups, outdoor visitation, not visitation, but meetings, the limit is 100 persons and masks are required. And again, outdoor groups can meet in larger numbers if they limit themselves to 30% of seating capacity, if there is fixed seating, and no more than 30 persons per 1,000 square feet if there is not fixed seating. And of course, masks are required. Also last week on Tuesday, Gordon issued another order that pretty much merges most of what was in Executive Order 191 and also Executive Order 171. Excuse me. You will note that the guidance about the disposition of COVID patients and the regional hubs, that information is not included in this order. But remember that the state put out a care and recovery center guidance in late September. So there is still information, all of those requirements and guidance about how to apply disposition, how to place COVID positive residents is still out there. And we did go through that care and recovery guidance last week. So although it's not written here, there are still updates about how to transfer and place COVID positive patients. I'm going to try and move quickly through this guidance since it's really mostly a combination of old executive orders. But what combining these two orders does now is it puts independent living facilities under the same communal dining rooms as other facilities. And we're not sure if that was intentional or not, but as written, that is what it says. It doesn't seem at this point that there might be much impact to that since the rules for communal dining and group activities have been made more flexible. But merging these two together puts independent living also in what used to be Executive Order 191. So facilities are to use the communal dining standards that are listed in QSO 2039 for nursing homes. And pretty much they simply align the social distancing standards with dining requirements. In addition, in this emergency order, facilities must inform residents, employees of any COVID positive case in 12 hours. That, of course, is not new. And on the right side of the slide, there are some relatively new requirements. Within 24 hours, the facility must inform any legal guardians or representatives of new cases, and also post a conspicuous notice at the entrance for at least 14 days following the identification of any new cases. Another relatively new piece is that facilities must implement a protocol to inform any prospective residents or staff of any positive cases, and they have to have that protocol in place for at least 14 days following identification of the last positive case. And of course, it's not new that you have to contact the local health department for any new cases at all, and support and comply with any tracing efforts. And then the guidance goes on to repeat the current visitation guidance for all those settings. Visitors are still prohibited for any indoor visits unless meeting the criteria for exceptions for people who might need ADL support, people who need visits related to guardianship or durable power of attorney work, or of course those in serious or critical conditions. The guide also provides for timely notification to staff of any CDC updates, and of course reporting requirements for nursing homes overall, and neither of those things are new. The guidance also includes the previous recent rules for outdoor visitation and the need for social distancing for that visitation, with some additional requirements for protection from weather, and that there must be staff or volunteers who are trained in elements of infection control. And these persons must be in proximity to observe and to ensure compliance. Indoor visits for those persons meeting the exception criteria must be scheduled in advance. Visits for ADL support must be designed for specific and individualized tasks. They should only occur in the resident room if private, if that works, or in a designated area otherwise. Visitors, of course, must wear masks at all times, and the facility must ensure compliance through training for those visits. The visitors must be trained to assist in the ways that they're intended to, and observation of the visit itself. Window visits are allowed and must be made available to persons who even may reside in upper stories of your facility if such exist. Resident physicians and clinical students are considered part of the medical provider group that can enter the facility, but they must adhere to testing and PPE requirements along with everyone else. All visitation is by appointment, and facilities should have clear policies about requirements regarding timing, logging, contact information, number of persons allowed, and screening. All the guidance lists a preference for outdoor visits when feasible. All areas must be well ventilated. External medical service providers are considered essential, as we said before, and they must adhere to PPE and testing. Non-medical providers can also be allowed when there is negative impact without their services. They are also required to adhere to PPE and testing as needed. And of course, on the right side of this slide, there's a long list of basic facility requirements and structures for visiting. And none of these are new, so we're not going to go through them. So not a lot has changed in this guidance. A few things were updated in the past 2 weeks, but basically it is simply a combination of most of those 2 executive orders. And just before all these emergency orders were needed because of the Supreme Court case, the department was producing its second iteration of Visitation FAQs. So we're going to run through those fairly quickly here. In order to provide outdoor visitation, everyone's reminded that the facility must have had no new facility acquired or staff cases for the past 14 days. All staff cases have to be treated as if they're an outbreak. Everyone needs to remember that there is no differentiation between whether you think that they acquired it in the facility or out. For residents, though, you only have to address new facility acquired cases as in terms of an outbreak. Local health departments must have not determined that the facility is located in an unsafe transmission area. And of course, the facility must be able to meet all of the safety precautions. If you remember from that guidance, as we just said, the local health departments have the responsibility and basically the right to adjust requirements based on the local situation. And we had a member late of the week prior to this week whose health department was prohibiting outdoor visitation based on some very, very high standards for county positivity and case rates. So we talked to the department about this. It seemed like those criteria were very severe, and it was obvious that they were not consistent across the counties as we could see. So the department now has issued regional criteria that are much broader for when local health departments should consider prohibiting outdoor visits. So a daily caseload of more than 150 per million population, or a positivity rate of 20% or higher over a 7-day period. And those are pretty high benchmarks to meet, pretty broad. So that'll make things a little bit more consistent across the regions. The new visitation FAQs also allow voting assistance as non-medical service providers. That would be important to help with resident voting. Safety precautions, of course, must be applied. And nursing homes must also remember that they have to adhere to the standard requirements for resident voting. And all of that was recently issued through a QSO memo 2102 nursing home. In the FAQs, the department clarified the use of volunteers. They can schedule, screen, escort, but not transfer people, but escort them and act as monitors for visits. And they have included here a list of training requirements, which are not very deep and would be expected. Additionally, facilities must have policies and procedures for visitation, including training requirements for staff and volunteers. There needs to be details about the visitation rules themselves, the requirements to log, the number of people allowed, etc. A communication plan for residents, family, and staff. And they also note that facilities should not use volunteers who are at high medical risk for COVID. This week, the CDC put out new guidance about how COVID is spread. I think it pretty much only verifies what a lot of the thinking is out there now. The most common form of transmission is through droplets during close contact. They do note that as the concentration of the virus decreases in those droplets with both distance and as well as the timing of the infection for the infected person. In other words, the further you are from a person, the concentration of virus in the droplets that move out is less. And also, you're going to have less virus in the droplets depending on how far the infected person has been from onset. So the longer they have been recuperating, obviously the smaller the amount of virus in the droplets. So transmission is less common through touching infected surfaces, and it's also less commonly transmitted through airborne situations. But the CDC does note that it can be transmitted that way. And so it's important to be careful in closed spaces with poor ventilation, or when persons are singing or exerting themselves in exercise. That's when they believe that it's more likely to have airborne transmission. Again, it's less common, but it can happen. A few updates on provider relief grants. The phase 3 distribution has started, and applications could be submitted as of last Monday, October 5th, and the deadline is November 6th. HHS suggests that providers submit early. Basically, these grants have the same terms and conditions as the earlier grants. But for these, even if you've received a payment that totals 2% of your annual patient revenue, you can still apply if you anticipate greater losses. And the criteria for qualification overall is you had to have billed Medicaid between January 2018 through March 2020, or billed Medicare fee-for-service between January 2019 and March 2020. Or if you billed Medicare Part A from January 19th and had a change in ownership during that time. If you were a state licensed assisted living facility, as of March 2020, you could be eligible. And one of the newer criteria is if you provided behavioral health and billed insurance or not billed insurance, either way, as of March 2020. Some dental plans were included, but I didn't list them here. They didn't seem pertinent. And the other thing is that if you received a prior targeted payment, and SNFs did do that, you're automatically allowed to consider another distribution if you meet the additional criteria for phase 3. So these are the application requirements. We're not going to go through them in detail. They're not really different from the previous grants, but they do outline the overall process. And the details are also included in the link that's on the left side of the slide. That's the basic HHS website in order to apply. So how they're going to do this. The first review by HHS for these last set of applications, they're going to do that review to ensure that all providers who have applied have received at least 2% of patient care revenue during prior distributions. If not, a qualified provider will be allocated those funds. Then they will calculate add-on payments that will be based on changes in revenues and expenses. If you think that you're going to have more decreased revenues and higher expenses, and they look at that against payments already received. There is an FAQ out for this, and it is listed on your slide. But also remember that reporting and how you're going to determine whether or not you get to keep the money in the long run is standard for all of these distributions and was recently updated by HHS as well. Additionally, the rules for Medicare advance payments were made significantly less stringent. They allow for now a total of 29 months for recoupment, which is an amazing increase in time. Loans will be interest-free during that time, and any outstanding loan after that time, they'll be subjected to a 4% interest rate. So there's a lot of information here about testing in nursing homes. And even though this is a CDC update for testing in nursing homes, we do encourage all members to review it. It has a lot of good information about how to think about testing and follow-up. to testing, and a lot about the overall protocols and the rationale about why they do things. So even though this is technically for nursing home, we think that it's helpful for everyone. The link to the FAQs is listed here. And the CDC has probably 10 or 12 questions that it responds to regarding testing and how to think about it. So when testing resources are scarce, they do have a priority system that should be applied. Obviously, residents and staff with symptoms, if there's an outbreak, followed by any serial testing as required by CMS related to that outbreak, obviously that's a priority. However, they do know that when testing capacity is limited, if you cannot get a 2-day turnaround time for results, the tests overall are less meaningful. So if you're doing serial testing and you can't get the test back in 2 days, they think that that should be a lower priority. However, even though it says that, that doesn't mean that you don't have to continue and try to do serial testing here in Michigan, but you should be notifying the state to try and get some assistance with testing if you're doing testing and you still can't get your results back in 48 hours. CMS requires testing every 3 to 7 days in response to an outbreak, and the CDC tells you, gives you more description on how to think about that. Most cases they find during an outbreak are found within those first 2 weeks. So what that means is transmission occurred before the outbreak was known. So they think that members, facilities should consider testing every 3 days for about the first 2 weeks, and then every 7 days until 14 days after the last case. So they include examples of a testing cadence that tests at 3, 6, 9 days for the first 2 weeks, and then moves to 12, 19, and 26 days further out. But if testing capacity is severely limited, they believe that you must test at least every 7 days. But if you can, for the first 2 weeks, you should test every 3. And again, they note that testing will not help any situation where there is not adherence to strict infection control. And again, they warn providers that they really should be getting results within 2 days. The CDC also notes that unrecognized COVID is most often introduced through staff. So they believe that testing of residents is not really that important, except for during outbreaks and for symptoms. Regular testing of residents, they believe, can result in false positives and alarm people unnecessarily. So routine testing for residents should really only be considered for maybe those who frequently leave for treatment, and especially if you're in a high transmission area. But again, they feel that only if you have resources to do that, it's a lower priority, but it is an option. They believe that the benefit of serial resident testing is still unknown. So information about antigen tests, the specificity or the ability to identify the virus is similar between the antigen test and the PCR test. And false positives can occur with any test. So you should only consider that an antigen test may be a false positive when the result is inconsistent with the situation. And that's what that CDC graphic that we talked about several weeks ago said. So if you think you might have a false positive, the first thing you should do is check the FDA guidance for the correct use of the test. Consider whether or not you have an appropriate transport medium. In other words, you're putting the specimen in the right kind of medium. You can also check the accuracy of the machine by doing a procedural control check. Facilities can also compare the positivity of an overall sample run for a day or a week. And what they mean by that is you can look at how you have done your test for this day, or if you're doing it across a week, to determine if there's any clusters of false positives that might provide some ideas that it could be an operator error, or that you might have some flawed supplies. And of course, always go back to the CDC graphic about when to get a confirmatory test, especially when you have a positive finding, a positive antigen finding in a low prevalence area. So you should conduct a confirmatory test when there is an asymptomatic positive found with an antigen test. They suggest to use a PCR test, but if you cannot get results in 2 days or less from a PCR test, they consider it meaningless. So they suggest that you use a different kind of point of care test. And I'm not sure that members have access to that, but it is possible that if you can get a different type of POC, point of care machine, that would be an appropriate confirmatory test as well. For any confirmatory test, you should ensure that you can get a high quality sample. Excuse me. And if you are doing a confirmatory test, try to select a PCR test with high specificity, and make sure you do the second test within 2 days of the POC test. Excuse me. If you think you have a false positive, those persons still must be immediately placed in transmission-based precaution. But you can delay outbreak testing until you have a confirmatory test. If it's a staff person, obviously you must exclude them from work. If it's a resident, you can move them to a private room if needed, if available, along with applying transmission-based precautions. But if you don't have a good space available, it's recommended that you don't move them, but you certainly don't also want to put them in with any new roommate. It's important that if you really think you have a false positive, that you not put them in the COVID unit until you have confirmed the test. Go back. I think that there's a few other things that I wanted to talk about that was on that slide, Blake. I'm sorry. So persons who have symptoms and a negative point of care test, again, should be confirmed with a PCR test. And of course, those persons would have been immediately placed on precautions. So anybody who has symptoms, a negative point of care test, confirm it with a PCR test, but you still treat them as positive. Using a point of care test, the CDC considers it still better than a PCR test if you can't get those PCR results within 2 days. You should not do a confirmatory test for anyone with symptoms or who has been exposed and test positive with a POC test. So if for some reason a PCR confirmatory test was done and they had symptoms, you still have to continue to isolate if the confirmatory test was negative. So if you have a positive point of care, a negative PCR, you still have to isolate for anybody who has symptoms and continue transmission-based precautions if that person either had symptoms or close contact, either one. So you should still treat these cases as positive. It's possible that the PCR test could be wrong as well. If a person is not symptomatic and the point of care test was positive, but the PCR test was negative, you can monitor them closely. And if they later develop symptoms, you immediately treat them as positive and isolate them, and you don't need to do any repeat testing. If they're asymptomatic, again with a positive POC, followed by a negative PCR, but they're in a low prevalence area, that is the scenario where you have to go to your clinician, look at what's going on with the person, monitor them perhaps talk to your local health department. But you don't have to institute outbreak control, but you should be reporting to the FDA about this situation according to the CDC. Persons with positive antibody tests still have to undergo routine testing. It's very much not clear how long any immunity will last. Residents who decline testing with symptoms still have to be placed in transmission-based precautions. And there's nothing new in this piece. I think that we have all seen guidance that talks about what to do with persons who decline. And of course, only persons who test positive should ever be placed in a COVID unit. So before we move on to the next slide, I want to make sure that everyone understands that we know that this is a very complex testing scenario, and the CDC puts it out in chunks of information based on FAQs. So what we're going to do is we're going to try and maybe make this a little bit more concise. There's a lot of good information here about what to do with testing, and so we hope to have that perhaps done by next week. A couple final discussion pieces, the surveyors for nursing homes. Laura's been working on a document to guide surveyors in terms of cohorting requirements, including cohorting following outside appointments, and we know that that's been a really important issue. The document that they've created is being distributed to surveyors this week. The changes that we have seen, and we were allowed to provide some input into this document, are significant and positive for members. So hopefully it'll be released next week, and we will review it in our Wednesday webinar. So again, I want to remind everyone that we know the testing guidance was complicated. We're going to try and put out something a little bit more streamlined, but I do think that information was very helpful in terms of scenarios. And we do recommend that everyone, not just nursing homes, review the CDC guidance, and the link was on the slide. So you can move forward. Any questions?
All right, we do just have a few questions, so I will just hop into those. With outdoor visitation, why is a table recommended?
Tables recommended as a way to create a 6-foot barrier, but it's not in any way required. There are also other recommendations for maintaining that barrier, such as marking places, etc. A table is recommended, not required at all.
Okay. Does no visitation for 14-day quarantine pertain to those on hospice also?
I'm trying to make sure I understand the question. So are you saying that if you have a new admission or if someone is positive for COVID and also hospice, whether or not there's a requirement for no visitation? Is that the question? I guess.
Do you want me to move on to the next question and maybe have them?
Yeah, yes. I'll try to respond to that separately.
She said if we have a positive staff and put on quarantine.
The question is, say both questions again if they're related.
Okay. Does no visitation for 14-day quarantine pertain to those on hospice also? And then she said if we have a positive staff and put on quarantine.
If you have, you're allowed exceptions to the visitation. To be honest with you, my brain's a little fried. I'll have to go back and look, but my understanding is that the exceptions are the exceptions, whether or not you have a COVID positive case or not. My brain is not remembering that. So let me look into that, but I would be hard pressed to deny someone compassionate care at the end of life because you had a staff member who might have tested positive. So if I understand that correctly, let me look into that further.
Okay. Since the weekly testing requirement was originally based on the Michigan START map, do we expect? Oops, it moved. Do we expect any updates that line up with the CMS guidance of monthly if test positivity in your county is below 5%?
Well, if you're asking me personally if I expect the state to change it, my answer would be no, I don't. Whenever we talk to the department, they have huge concerns about transmission in nursing homes and other long-term care facilities. They still tend to be very, very cautious, hence the visitation issue with CMS is still hanging out there. I actually do not anticipate that at all, at least not for a while, and that isn't required just on an executive order. There's already emergency orders that require that in Michigan, so that's really not in the up in the air right now.
If an employee has had COVID, do they still not have to be tested for the next 90 days, or did that change?
That has not changed. There's no point in testing someone who's been known to be COVID positive for 90 days.
Okay. Yesterday on the CDC CMS Q&A, someone asked if you need to quarantine a recently recovered COVID positive resident if they were returning from the hospital, and they said no because you wouldn't consider testing for 3 months. Thoughts? That's
true. There is no point in quarantining someone that you know was just recovering. So the answer is no, you don't have to quarantine those persons.
Okay. If you have an end-of-life situation for someone in the isolating wing or observation wing, can we allow visits?
That's the same question I think that came back earlier. My understanding off the top of my head is yes, you should be providing compassionate visits to anyone who needs them. But let me check, simply because it's Friday and my brain's a little fried. Let me check into that a little bit further.
Is there any communication from Michigan as to aligning with CDC in terms of visitation directives? We're still placed in the middle of these opposing directives.
Yes, and the answer is we are still in the middle of the conflict between Michigan and CMS. We have sent a note to CMS asking them directly what their recommendations are, considering the fact that Michigan is still kind of on hold with their CMS guidance. We've not heard back from CMS, and we've asked, of course, the department numerous times. It's obvious that there are significant fears, and I think mostly from the epidemiologists at MDHHS, which is why they're trying to be so cautious.
All right. And then just someone said that the CDC testing link was not working and they can't get to the page.
Okay, for some reason, and I don't know this, if you're trying to link off of our PowerPoint, it doesn't work that way. You have to cut and paste it. But I will make sure that in our update this afternoon, we send you out a good link. I was able to get to it yesterday. And I do, again, encourage everyone to follow that. It is extremely helpful if you're doing testing and how to think about point of care tests.
All right. Thank you, Deanna. Right now, it looks like that was the last question. So if anything else does pop up, feel free to shoot an email off to Dalton, Deanna, or our Safe and Calm webinar email, and we will make sure to get that question answered for you. So other than that, we would just like to thank Dalton and Deanna, and we would also like to thank Phyllis for joining us earlier. And we would also like to thank, I believe we had around 85 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. I hope everyone enjoys the rest of their Friday and has a great weekend. It looks like we're actually going to have some nice weather, so get out and enjoy that. And we will reconvene with our next Safe and Calm webinar on Wednesday at 10 a.m. Eastern Standard Time. So we will see you then.
Thank you, everyone. Have a good day.